to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay. First item on the agenda.
Can you give me 30 seconds?
After all this? Are you not recording?
I will be in a second. With all the kerfuffle over Ken, I failed to start.
Oh, okay.
We are now.
Are we on?
We are.
Okay. Do we have public comment? Hearing no public comments, we'll go forward with the approval of the consent agenda. Have you had a chance to read the minutes?
Actually, I looked at them today, yes.
Well, good. I'm proud of you.
They look fine, so I move we approve the consent agenda.
Second.
Okay, been moved and seconded to approve the consent agenda. All those in favor?
Aye.
Okay. So now, Mr. Ed,
Yes.
we're on with the Lhd Financial Reports.
All right.
And you are the master of your you're the master.
Okay, so this is a financial report for November 2021. The one piece that's missing are the statistics due to COVID. We do have a ticket in Discerner to automate that whole process so that we won't rely on necessarily totally on humans for these numbers. It's not that we weren't tracking them, but the person that compiles the final thing had some issues.
Are you talking about COVID dollars?
No, staff analysts.
Statistics on how things are, how many visits,
Oh. In cases of.
all
So those will be distributed most likely by tomorrow afternoon for both November and December.
Okay, because these go through November. I was hoping for a little update on December, how far.
Oh,
we're on.
absolutely.
Yeah.
And that's what, the information I have for December, I'll definitely share with you in this report because I know we're kind of timed reporting. But so for November, this gross patient charges are 4.146, so it's right about budget. And you can see it's staying steady. If that's a reflection of visits, to some degree. December, it's same thing, it's 4.08 million for December. For collections, now this is the tough one, is the 1.9 million. For December, they are currently at 3.088 million. So we do this downswing and then this upswing. And it should be noted that with the exception of the manager, that department now is fully staffed. They're spending about 4 hours a week training, and they're partnered with more senior billers so that they know what they're doing from the get-go. And so that we don't have something like that, Honestly, I can't pinpoint it to one thing. A lot of payers were not paying in a lot of ways, and part of it is holidays, but we're just getting after it every day and rolling up our sleeves. So one thing to note is over the holiday period, November and December, Thanksgiving and Christmas and now New Year's, we had 2 or 3 individuals that pushed out like 3,000, 4,000 claims in catch-up. So you're going to see quite a turn. It's just not as fast as we'd like it. And we're throwing we have 16 people working on that project, both on the old AR and the new AR. So I was really disappointed by those. But I know that December is already way better in January.
Any update on our contractors getting the old stuff in?
Yeah, absolutely. I was gonna I actually have a slide for that, and I'll give you a full update. And kind of a plus and minus. on that. Days cash on hand went up to 89. Compared to last year, it's an extra month, which is
Believe it or
nice.
not, probably collection month for 89 days.
Yes, I know, it's just, I went back and checked it like 3 times because it didn't make sense when I was doing it, but. So this, for the monthly net income for November, we had 4.1 in gross revenue, less revenue deductions of 1.04 million. You see it's a little slight uptick, but we're doing cleanup, that's part of it. Less expenses of 3.5, and I know it's showing up there as 3.7, but that's also the below the line interest, depreciation, and everything is in that 3.7 number. So truly, our operating is about 3.031. But like I showed in the details, we have a couple one-offs that in a later slide I'll try to minimize. And then year to date, through November, total, whoops. There we go. Year to date through November, total revenue of 15.5 million. So we're still that 975 under the budgeted, but it's out there to be gotten. So I think we'll finish ahead now. Less operating expenses is 16.5, so we're underspent by 250K. Plus the non-operating revenue and expenses. So when it's a positive number down there, it's adding to the expense. Where it's a negative, it's kind of deducting from it. That's why you saw that 2 million to 3.7. It's really the stuff that's not operational that's going on that kind of skewing it a little bit. If that makes any sense.
So one of the things that you should note in October, where we had that 905,
One EOCCO.
so if some of that is the way EOCCO pays us, they pay us 90%, hold back 10%. So some of that refund was that added 10%. So theoretically, we could put that above the line. Some of it is bonus money. And the bonus money is based on if we met the metrics, if the CCO met the metrics, and if all the CCOs. So there's a variety of different factors. If we have the number below the line as a non-operating, then that benefits our cost recovery. If you could maybe split out some of it and put it above the line, that was really vital, but it's the recommendation of the auditors to keep it as we have.
Speaking of the auditors, I noticed you made an adjustment with the depreciation. Is that for the auditors?
Yes, for 2021. So it's a 2021 expense. Before giving the trial balance to the auditors, that was done. They did their on-site review, I want to say the first week of December. So I think we'll expect financials here in the next week or two, possibly.
Really, in 2 weeks?
What Eric said is by January 30th. Because I emailed him this morning and asked for a commitment, and he said it was due November 30. They got a 60-day extension. They will take the full 60 days.
Okay, and that includes cost report too then, doesn't it?
That is the cost report, not for the audit.
Not for the audit.
Correct. So the state requires that we file by 6 months or 5 months from year end.
Right.
And that's November 30th.
Correct.
They asked for an extension of 60 days. The state gave them that.
So when will we probably see, the board will see it on the audit report? Would be your guess.
If I were betting, I'd say the end of February. They might give it to us sooner. What would you say?
I'm hoping for 2 weeks, but unfortunately they haven't. It seems like even up in Spokane, they're having the same issues we have here, so getting everything done. With staffing.
I think we're all impacted by, what was it, 4 million people that quit working in November? On a national basis, and I think that impacts not just us, but every industry. And it's just difficult to get anything accomplished.
And you mentioned at our finance meeting on Monday that one of the things that caused the $620,000 loss was some of the way some of the grants were classified, et cetera.
Right.
How much do you think that affected?
To some degree, like where we were basically, I don't wanna call it stockpiling or anything, but preparing for a new COVID, uptick, you know, whether it be the supplies or, you know, the vehicles that were purchased for the, you know, upcoming, different grants we have going on that are expiring on 12/31. We don't want it to, we want it to be below the line and not affect it.
The grant shouldn't really hit our balance sheet, it shouldn't hit our P&L.
Well, for some, to expense it to the grant, it has to be an expense and it can't be an asset.
Right, but let's say you get a $10,000 grant, you wouldn't book that as income, you book that as a grant, and then when you spend the money, you build an accrual for that.
Right.
And then that shouldn't.
In most cases, cause I thought long and hard about this, cause I like to recognize that revenue when we expense it, my personal. But there's some of this stuff like the PRF fund where it's revenue replacement and that you could recognize right away. Cause most of that one, the bonus, the 905 or the 778, whatever it was, we recognize that now or in the year it was accrued.
Yeah, but most grants are passed through, in other words, you get a grant, but you have to spend it by the state or
Yes.
do the following things. That shouldn't affect our P&L, I mean, if you got the 10,000, you accrue the 10,000, as you're spending, you go against the accrual. So.
Correct, in most cases.
Yeah.
In most cases, and actually, it would be helpful too, is to come back and kind of line out, okay, this is where this flew to, this is where this went to, and that way we just have a clear picture.
And did you see the spreadsheet we got from?
I did, Charlotte today.
I can show you some of, some of this, we're now getting, that's why we hired a grants manager. It's becoming bigger and bigger as an impact for the district. Ken, you were on the board when we engaged a grant writer in 2009 and 2010. And we didn't get any grants. And now we're at 1+ million.
But we'll only keep getting them if we execute what we said we did, so that's.
Absolutely. And so this didn't just happen overnight. It's been occurring more and more as we show that when we say we're gonna do something, we actually use that money and accomplish what they are asking for. The grant writer, or our grant writers, is doing an exceptional job. And the funders are very interested in giving us money. We just have to make sure we're doing it correctly and spending the money correctly. And a lot of times it's hard to spend the kind of money that they are giving us to find problems. The results with all the money we have for COVID, if we don't spend it, we have to give it back. And we're not going to squander it. But a perfect example, one of the grants that money had to be spent by the end of this last year. And so we arranged with our vendor, because it's for COVID testing, we don't have the capacity to buy all the testing equipment or the supplies and store it here. It may go bad on us. We may not do that many tests. So we arranged to give them the money, they hold it into account for us, and then as we use it, that it takes away from that amount. That met the intent of the grant. It doesn't squander the money and allows us to buy it over time. So it's those kinds of things that we're working hard to make sure we get there and do it in a thoughtful way.
Okay, thank you.
All right, net margin, for November had $219,000 decrease over the margin of the previous year. It's still, I don't know why November historically for the last 4 years is in the wrong direction. But I'm not setting the record in the right way, so we're very hard to correct that.
But you have a great October, if you're following like November.
Yeah, and then if you look at the totals for the year, it's 205 and average at 41 versus the negative 63. Still overall, as much as we don't like peaks and valleys, it's still trending upward. It's not as quickly as I would like. So the 6-month trend, the same thing where I'm trying to normalize it as best I can, taking off the one-off, if we do, a large purchase and trying to minimize it, but you see the 193 and then our year to date is what, 205 or 219, or 205, I'm sorry. And our budget was 219. That's pretty close. I mean, that's next to the balance sheet. And like I said, and I probably should have done a slide to outline kind of the prior period adjustments, but we're waiting for the auditor's final say on that. So I said they're the ones that are combing through it right now and making sure it meets their gap standards. So. In our project, so I'm going to speak to this a little bit. So this is HRG, the facility is like our responsibility. This is the for all payers over 90. For Medicare, it's 30 and over because we had a big tranche of money there. They were credentialed to do it, where our person hadn't received their credentials yet. It took about 90 days almost to get that person with the Medicare credential. And so in their inventory, they basically had 4,000 of our accounts, or 7 million. And you can see the breakdown, the 905 to insurance for a total of 1.6 million. And that was collection. So in the month of November, they collected 323,000. At a cost of 26,000. Overall, for the whole project through December, it's the 1.6 million at a cost to the hospital of 80,000.
Where's the one? Oh, insurance.
Yeah, so the insurance, that's basically meaning that that's been sent and submitted and approved through the claim.
HRG has 4 million out.
Yes, and my thoughts on that are that, that 905 out of a total of 4,000 accounts is not significant enough, and in my opinion, that if you work out the production, they have 4 to 6 people on staff at all times, and
So you're saying they're managing the 6.9 or 4.2?
they actually manage the 6.9, that's our over 90, and a little bit over 30, but my thing is with that is, when I calculated it out today, and I haven't even sent it to Charlie, we're gonna do a call tomorrow with them, but we gave them like a sweet $1.3 million pool of Medicare because we weren't credentialed yet for that, with our turning over and people going to different places. And I wasn't pleased with the number. Like, that was where I promised you guys last week we would collect an extra $1 million this month.
Right.
That was behind that 30 to 90 day Medicare money. And when we looked at the statistics today, it hasn't been processed yet. They processed 9 for a total of $160.
What do they say? I mean, why?
No, that's what we're getting on the phone with them tomorrow.
We had tried to get to them earlier, but because I was out, it made it difficult for schedules to get worked out.
Yeah, so
We are well aware of the issues.
Well, it's 7 million, a total of 12.5, so it's a significant part of the inlet.
and we're not seeing the normal process that they would be doing. I mean, they have the technology to really push through stuff, and they're not, so.
They should have some, they better have some answers.
They
Yes.
better have some answers, is exactly correct.
Yes.
And their agreement is up for renewal, and so they'll be saying, well, wouldn't you like us to pay us some more? So we will be talking with them.
But it's a results-based payment though too, isn't it?
Yes.
Absolutely.
That's all I had for the LHD report.
Do you have questions? No, okay. So Ed, you're still up with Goose Lake Medical.
All right. Okay, Lakeview Gardens, for the month of November, revenue of 218, expenses of 419. You see the wages, the little bump up there. Contract labor was a little higher. Medical supplies a little higher, same thing, we're paying invoices, trying to close out the 1099 year, which even though it's not our fiscal year, the vendors are doing it, so. And that's what, there's an uptick in a couple of the expense line items, it's making sure that everything is paid for the calendar year.
This is November.
Yes, but I mean, it's just, our whole thing, hey, make sure that we're 100% captured all expenses by 12/31 for the vendor side of the thing. So, the net income was, a deficit of 200,766 and year-to-date of 873.02. Next slide here, Lake Health Medical Supply.
Well, they do this.
Yeah, and the only, here's another accrual issue that you see that
Wages
it's like,
doubled.
it's a one-time, something that was a,
Thanksgiving bonus.
We have an annual bonus as part of the program, and we hadn't calculated for a couple of years. We went back and reassessed it and made sure we were doing it correctly and made the adjustments. And paid appropriately for what we need. So we will now be more correct.
Well, this has been a significant turnaround this year, so it's one blip, but I mean, it's very pleasing to see this turned around.
And I expected to, if one of the consultants that I'm talking to does fulfill his abilities, we could see a 50% increase in our revenue. So that's what I'm gonna hold him to.
yeah, they're taking a real proactive approach, those guys. I mean, they're training in the clinic every day. They're chasing down all the EOBs and the authorizations.
You don't know what that means.
Oh, no, I mean, making sure that they have all their
What's an EOB?
estimate of benefits, explanation of benefits, I'm sorry.
What they're doing is getting all of the signed documents that the doctors have to sign off to get
Oh,
the components.
to get reimbursed.
Right. So this morning, for an example, they spent an hour training the medical assistants on how to get it and what they have to do to meet Medicare standards. It'll make a difference the next month. That's all I have.
Okay.
Any other questions? Okay. Looking at medical staff update.
So I failed to send, there's a couple things I failed to do, sorry. But since I am wearing Jim's hat right now, we have 3 applicants that were approved by the medical staff at the medical staff meeting in December. And the 3 are Laura Lane, CRNA, Landon Morkison, CRNA, and Tao Vu, a physician who's also
So what does CRNA stand for? That's it.
a certified registered nurse anesthetist. And so the applications have been reviewed in toto by the medical staff, and they recommend that you approve their applications. They're all here for you to review. I don't know if, did Jen send you the full applications in the past? Just the cover letter
Just the cover letter that's signed off by the physicians.
by the physician?
Right.
That's all you got?
That's typically all we get unless
Okay.
we ask for other
Okay, so,
information.
sorry, I failed to send that.
This would get us back in business and anesthesia surgery.
It's helping us get there.
These are all locums.
Well,
Well, travelers.
They're all fill-ins, they're locums, they're not ours. Our first permanent CRNA starts
February 14th.
February, is it the 14th?
as a permanent employee.
So she's
Yes.
permanent, she's 2 weeks on and 2 weeks off. So we'll start to see a change, there, but we're still working out what to do with the other 2 weeks. I kind of have
These two, maybe?
I have a group. Probably not these, but I do have now kind of a stable group. So it's filled into July, I think.
This typically had been my responsibility, and Teresa's been helping, doing it, not helping, doing it, to find these nurse anesthetists, or in the case of Dr. Vu, an anesthesiologist. It's still really difficult to do. And you've heard us talk about the impact financially of these challenges. It's extraordinary. But we don't have much choice. So if you were to look at the schedule that Teresa has worked out, and every one of those, they're good nurse anesthetists. I mean, these are all good clinicians. It's just hard to get them organized. And it's taken an enormous amount of work and extraordinary.
So, do you need the board to approve these?
I do.
This is standard.
This is, anytime the medical staff reviews applications for providing services here, but just as a reminder, the way that a physician or a mid-level who is authorized to provide service in a hospital, the way they get the right to do that, they have a license in the state, but they have to be authorized to provide certain procedures or services within a hospital.
They have to be vetted.
So, number one, we go through and vet their background. And then, two, we make sure that they say who they are, who they say they are. So there's all sorts of ways we validate their medical school or their school, whatever education they have. That if they have practiced at other hospitals and they have to get recommendations from other hospitals, that they have malpractice has been validated, and if they have past history of claims, we need to know about that. Then once they come here, the physicians will review and determine if they're capable of providing certain services. So a general surgeon, Dr. Chang as an example, he can't just do brain surgery here if he hasn't proven that he can. He can do within his scope as a surgeon. But if he wants to do extraordinary things, the medical staff reviews his capabilities of doing that. Same thing with other physicians. If they want to provide a specific service within the hospital, their peers look at those requests and determine if that person is capable. Once they've gone through that, voted, that is what is then coming to you. So you can be assured that we've validated everything we can about them. And two, the medical staff has reviewed their application and their request for specific services, and so we grant you the right to do that. Okay, that's the process. And then they're not fully approved to practice at the hospital until the board of directors approves that application. So that's the final step. That's what we're at. Does that make sense? Any questions? So So I
This
would
has been
recommend,
almost every board meeting we've had this.
Yes.
Just about, yeah. Okay. Do I hear a motion to accept the medical staff recommendations as presented?
I so move we accept the staff recommendations.
I'll second. Except for 3,
Correct. For Laura Lane, CRNA, Landon Morrison, CRNA, and Al Wu, MD.
yes. Second.
Okay, been moved and seconded. All those in favor?
Aye.
Okay.
Next, and we normally don't bring these to the board, but it has been recommended, as Sean Cosby has been going through all of our agreements and our relations with lots of hospitals. We have mutual aid agreements with multiple entities, whether it's we get with the town for providing us water, or we have relationships with other hospitals in the event there's a fire and we need to evacuate all of our patients. We have agreements worked out with other hospitals that we can send all of our patients. And they're gonna take care of them. How do we pay them? How do we get them back? All those components. So we work on and have a variety of different agreements. These 2 mutual aid agreements are with the school district number 7. And it is that we would share facilities if we needed to use the gymnasium, the kitchen, the bathroom facilities, anything of that nature, should we have to evacuate. They have both been signed by the school district. One is for the Lakeview Gardens and one is for Lake Health District. Would be my recommendation that while I haven't approved it, the board of directors will approve these mutual aid agreements.
Discussion?
That's for the use of the school's facilities.
If we have to send patients or our staff there, if there is some sort of disaster, and it could be for physical disaster, it could be a power outage, it could be a variety of different things. Now, if it's power out and it was just, we had backup power, but what if something like that couldn't work? Or we weren't able to cook.
The roof caved in or something.
Something, a variety of different things, any kind of disaster. It protects us and we need to have those protections. And the school needs that too, if something were to happen.
So does this also an agreement for the school to use our facilities in return? if
It's a
needed?
mutual aid, so we would go either way.
Good.
And hopefully it would never happen, but you want to be prepared in the event something were to happen. So I would recommend that you approve the 2 mutual aid agreements, one for Lake Health District and one for Lakeview Gardens.
I'll make that motion.
I'll second.
Okay, been moved and seconded to approve the mutual aid agreements as submitted. All those in favor?
Aye.
Okay. Teresa, you're up.
I am. Well, we continue to run at record high numbers. We reached our all-time high in the last couple weeks
Is that due to COVID?
ever. It is not.
You mean high as in patient count?
Into account. We have a record number of swing beds. We've increased the number. You know, we've had a target that we wouldn't accept more than a certain number. We've raised that ceiling, kind of to whatever. So we're running higher numbers of swing beds, as well as higher numbers of acute patients. So, I mean, it's becoming routine for us to say 15 instead of 10. And we've
What was the record?
the record was 22,
And we have space.
and we're a 24-bed facility. So
Wow.
yeah,
Not much room for error
we
there.
were pretty tight. We went on divert for about 24 hours. We came out,
Yesterday.
started yesterday and came off tonight. So we are, most of the time trying to accommodate. We have more staff in place, but we need more staff, so we still don't have enough. The staff that we have are a large number of travelers. So we have been lucky. For whatever reason, a number of staff have chosen to leave Sky Lakes, and so we've reaped the benefit of that, Sky Lakes ER. So that's been good for us. I can't say that's going to continue, but for right now, that's helping.
With some of the COVID challenges, when we go on divert, a lot of times, where do they divert?
It's kind of it's a nothing thing. It means nothing because you really can't divert because there's nowhere to send them. But the state staffing law requires that we recognize nurses' requests to go on divert. So I sort of have to go through those hoops, even though it ends up not always working out well.
Because you could call St. Charles and say, we're on divert, we need to send you a patient.
We-
Oh, sorry, we're
They're
full.
gonna say, we're not taking patients.
Yeah.
It does help. It helps to a certain extent because it gets all of our attention, all of our providers' attention to realize, hey, if I've got a patient that I can discharge, or at least move towards discharge, I can try to do that a little faster. So sometimes that's helpful. So that's kind of our staffings. We have, I don't have a lot of ideas as far as how to get in more permanent nursing staff. It's a tough world right now. We have one nurse scheduled to graduate in the spring from the KCC program. We probably have 4 people working on their prereqs to get into the nursing program, so they're a year or 2 or 4 out from graduating. So we have that in our future. CNA program got pushed back. We had at the very end, we had 2 applicants, and one of them had been through the program before. So we decided to postpone and try to get a bigger class. So that was a disappointment. For whatever reason, having one right after the holidays maybe wasn't the best timing, so we ended up not doing that. Otherwise, I think that we're trying to, things are running a little better as far as we get more used to Crna every month, and we get more used to COVID every month, and so things are returning back to normal. For the most part, we have, from a quality standpoint, gone over 60 days without a patient fall. So that's a kudo to the nursing staff because they work really hard to prevent patient falls. So we always celebrate that. After 30 days, they get pizza, and after 60 days, they get Mexican platters. So they're getting Mexican platters next week. So we have that coming up. In surgery, we still have several travel nurses, and we already talked about the CRNA situation. So I have to say, kudos back here to our cardiopulmonary manager. We do have some permanent staff on the horizon for cardiopulmonary, so we hope to decrease the use of travelers in the next couple months in that department. So Kim's been making a lot of positive changes in that area. So that's kind of where we're at.
Mostly staffing.
Staffing and more staffing, yes. It's a never ending. It's a treadmill we can't get off. So
Is the cardiopulmonary program at full capacity?
are we talking about cardiac rehab?
Cardiac rehab?
Cardiac rehab, I'll let you speak to that, Kim.
Sure. Cardiac rehab has always been pretty steady as far as I can tell. We have several patients that are waiting for pre-authorization for cardiac rehab. So to answer your question, no, we're not at capacity. We do have room to grow. And my hope is that with some new marketing efforts, some updated marketing efforts, we can get more patients in, not only with cardiac rehab, but with pulmonary rehab with our post-COVID patients, which I think I talked about a little bit last time. We have, I think, 3 patients who are waiting for authorization from insurance and all that for pulmonary rehab, which has been a little bit slower than cardiac rehab. From what I understand, Dr. Guaria, who is the cardiologist overseeing the program, he's really excited about getting more patients in our rehab programs, and from what I understand, he's willing to meet with our local providers and kind of encourage them and give them some new updated guidelines on which type of patients can go into rehab. From what I understand also, at the beginning of the year, there were some changes with ICD-10 codes, so the referral mechanism on how you can get patients approved for rehab. So, and the same goes for pulmonary rehab, because they've added post-COVID, from my understanding, as a diagnosis code. So that will help get some of these poor folks who are suffering from long COVID into our rehab program, because it not only will help improve their breathing over the course of the rehab, but it also helps with depression. It helps with activities of daily living. It helps with nutrition challenges, and gives these folks who are sitting at home really suffering and depressed and isolated a chance to be part of a program that's life-changing. It's not just helping them breathe, it's helping them overall. And I would say that both cardiac rehab and pulmonary rehab will do that together. So.
That's wonderful.
Yeah.
That's wonderful.
We actually just had a patient come in for another outpatient procedure, and she was just boasting about her husband was one of our first patients through our cardiac rehab program, and she said, "You guys need to have a health fair, you need to have open houses, we'll be spokespersons for you," because she said it changed my husband's life, and they're in their 80s. And he went through the cardiac rehab program, and he is doing well, and will have just wonderful effects from what he learned and how much he participated in the cardiac rehab program. So it's definitely worthwhile community programs that we have here.
Oh, it's great to have it in our community instead of.
Absolutely.
Yeah.
Absolutely.
And these are people that can't travel because of their conditions. So it really is important for them.
Great. Thank you very much.
You're welcome.
Is there anything else?
I don't think so, Charlie.
Okay. The CEO report. You're on deck, Charlie.
Before I start, Rebecca, anything you'd like to say? I didn't.
No, but we've got a lot of really good candidates lately for various positions around the facility. And really shockingly good candidates, and so we've had some really good interviews. We're just throwing out our fishing line with the offer letters and hopeful that we'll be able to get some really good strong bites and bring them in.
Are these, what's the spread of local and non-local?
Oh gosh, I would say
50-50.
it's more on the non-local side than the local side. Yeah. A lot of people are ready for a change, so it's good. That's it.
Thank you, Rebecca. Okay, now you're on, Charlie.
Sorry. I'm being ascribed to at the same time. So, a couple things that are going on as Rebecca said we had some good new candidates. We finally have secured a clinics director. Her name is Lisa Piquet, and she'll be starting sometime soon. I'm not sure if it'll be February or latter part of January, coming from the great state of Wisconsin. So traveling with weather is may have some impact on how quickly she can get here. We also have a new grants manager that has been hired, and that's Amy Hutchinson, and she will be working with our team to help us really stay on top of our grants. I think I sent out to you a lot of the grant information, and I hope that's helpful just to give you, it's not meant to give you an enormous amount of detail, but enough to understand we're at $1.1 million that's in the hopper, and that doesn't include another application we just submitted for a lot of money. I'm not sure how successful we will be, but the state put out a behavioral health resource network grant application, and they're called BURNS. Ed was involved in this, and we submitted an application, had to be done by December 9th, or the date got moved up in December. We were greatly encouraged to complete this, and mental health consultants that we work with through our CCO think we have a fairly good chance of getting it. If that's the case, that could add a great deal of benefit to our community for non-health hospital related services. We don't have places in our community for people to go that are sober locations, or places that are safe for people that have had addiction issues. That's very common in other communities. And so a lot of places in rural Oregon don't have that. And we're trying to get this. So we'll see. It's an astounding amount of money. We'll see if we're successful.
Set aside for North Lake as well?
I would handle a variety of different places.
Well, on this specific topic, what would the grant money actually provide and for what duration?
Well, until we get any indication that we would even be considered, I think it would be imprudent to say what we're planning on doing. We don't even know if we'll be a viable alternative. The state has promised a great deal of money to enhance mental health and how we're caring for it throughout the state. They've done that in the past. It hasn't been as robust as they promised. So I don't know how much money they really will. You know, if you ask for $1 million and they give you 100,000, the scale is such that you may not be able to do as much as you hope. So it's hard to say. But the fact that we're putting in applications is, we don't ask, we don't get. And I think and it took a lot of effort to try and get there. We'll see how that moves along. As of January 1, we will now be doing billing for the professional services in radiology. So right now, prior to January 1, if a patient came to the hospital and had a radiological procedure, a CT scan or something, they'd get a bill from the hospital, and then they would get a bill from court, the radiology. They approached us and said, would you be willing to do both of those? And we agreed to do that. And the benefit is that from the patient standpoint, they get one bill. So it's not as confusing. From our standpoint, it'll cover that cost. And it's a better working relationship with our radiology group. So we're hopeful that we've talked about this for a couple of years, but we wanted to wait until we've gotten comfortable with Cerner. And so the process, it's not a difficult process, but we want to make sure putting it well. So that's a new change. In the past, I talked about Dr. Foster, who had indicated he would be moving to part-time and then leaving us altogether. That changed. Dr. Foster now will be here full-time for the foreseeable future. He'll be working predominantly in clinic, so he won't be covering the emergency room. He will admit patients if he has a patient that needs to be admitted. But that, for him to focus on the clinic patients, that frees him up from having the responsibility of the emergency room services, which frankly was, he takes his patient care so seriously, it was affecting his health. So this is a good thing for us as a community and a good thing for him. So I'm very pleased about that. One thing I would like, we're working on our strategic goals that we talked about in November. And so each one of those, we're continuing to identify different components within them each month. I don't know if you'd like to have monthly reports, but we will be having a quarterly board planning meeting. So we can probably address many of those as we're moving forward. But I'm happy to address those if you would like. So, last thing that I have is we'd like to request that we move the board meeting from February 3 to February 10th. So a week later. It makes it a little bit easier from a finance standpoint to get the financial information prepared. And I have a conflict, so that will be helpful for me. Does anybody have any problem with that?
Good with me.
Okay. I did pass around the check signing schedule. If you can find a time that works for you. And if not, then those two that aren't here will be assigned the time that it's not comfortable for you.
I put in for two, that left two for the other two that's not here.
Okay. Do you have questions of me on any of the issues we can deal with? I would encourage all of you to, we have some tickets for the gala, Chamber of Commerce gala. That's will be on the, I think it's the 15th, 16th, I'm not sure exactly, 15th. So if you'd like to join us there. That concludes.
Is it gala or gala? That's
Depends on
always the
what part of the
question.
country you're from.
Yes.
Is it tomato or tomato?
I don't think we want to fight over that. Okay. With that, we'll adjourn to executive session under ORS 192-660, bracket 2, bracket A personnel, bracket C medical staff, bracket E real estate, and bracket H legal, with a 5-minute break.